And we will go ahead and get started while others trickle in. We will go ahead and get started. So formally, we want to welcome you to the first Stretch National Convening on Healing Relationships Authentically to Sustain a Healthy Community. My name is Valerie Henderson. I'm a senior analyst here at ASTHO, and I will be opening up the convening. I would also like to share a visual representation of myself for inclusivity. I am an African-American female in her late 20s. I'm wearing a purple shirt and glasses. Thank you all so much for being here. It is our hope that this session is enriching, fulfilling, and that you leave here with a nugget of knowledge that you didn't have before. Autumn, if you could go to the next screen, please. We would like to begin with a land acknowledgement to express gratitude and appreciation to those whose territories we reside on. We want to invite you to use your zip code to check the land where you live, work, and play. You can do that by texting your zip code to 855-917-5263 or by visiting the link below. The session will proceed as follows. We can go to the next screen. We will start out with a welcome and introduction by me of our partners. We'll have a panel discussion with our two guest panelists, and then at the end of the convening, we will take some time to connect with other folks that are in the room. And we can go to the next. Perfect. Your partners. So what is STRETCH? STRETCH stands for Strategies to Repair Equity and Transform Community Health Initiative. The CDC Foundation, the Association for State and Territorial Health Officials, ASTHO, and Michigan Public Health Institute, MPHI, have partnered again for the second iteration of what we're calling STRETCH 2.0. Built upon the experiences in the first round of the STRETCH initiative, STRETCH 2.0 aims to promote necessary skills, core competencies, power sharing, and authentic relationships among state team members and their community partners to advance and sustain health equity through systems change. The what? The what? So what are these national convenings that you speak of? Our 4 national convenings are open to anyone and everyone. This could span from public health practitioners, to clinicians, to state health officials, to community health workers, and leaders of many kinds. The why. Why have you all gathered here today? Through these convenings, we want to facilitate and foster peer-to-peer learning amongst community health practitioners as well as health equity practitioners. We would also like to promote tools and methods to operationalize equity, as well as expand core principles of the STRETCH initiative. Moving along to the fun part of today's session, we're going to go into our moderator. So our moderator is, for today, Dr. Alice Chenal, the Director of Cross-Sector Leadership and Facilitation at ASTHO. She will be facilitating this wonderful session that we have for you all today with our 2 panelists. Our panelist number 1 is Dr. Mark Neve. Dr. Mark Neve serves as the Executive Vice President for Institutional Advancement at UT Southwestern Medical Center. He is also a full professor in the UTSW Peter O'Donnell School of Public Health with a secondary appointment in the UT Southwestern Medical School Department of Family and Community Medicine, lecturing on health equity, diversity and inclusion, and underrepresentation in populations in academic medicine, and conducting research on the demographic and distribution of the physician workforce. Round of applause, let's welcome Dr. Mark Neve. Our second panelist is Dr. Edward Ellinger, he is board certified in internal medicine and pediatrics and is an adjunct professor in the School of Public Health at the University of Minnesota. He is a past president of the Minnesota Public Health Association, the North Central College Health Association, the Twin Cities Medical Association, the ASTHO, Association for State and Territorial Health Officials, and the first board chair of City Match. So these are well-qualified people, as you can see why we chose them to be our panelists today. Please give these two panelists a big virtual round of applause and prepare for an awesome panel discussion from our two guests. Thank you. And Alice, I will pass it to you.
Wonderful. Thank you so much, Valerie. Let's give Valerie a round, everyone. I'm so excited to be here with all of you today, and I'm super excited and honored to be able to actually facilitate this conversation between these two brain trusts of information and experience in the room, which includes all of you as well, might I add. When thinking about fractured relationships between a community and potentially an academic institution or even a state governmental public health agency, I begin to think about how we respond as humans when we experience a break in a bone, right? A fractured bone. So what happens? So full transparency, I do not have a clinical license to have this conversation outside of what's published, right? So if there's a fractured bone or a break in a part of with any of the bones in the body, typically what happens is first, it depends on the type of a break, you want to stop the bleed. Or second, you want to immobilize the bleed or the moving part, the injured part, right? A lot of times that may happen, depending upon the break, it would happen by splinting it or even by, putting a cast on. And then what happens is you want to limit the swelling and relieve the pain. So sometimes there's ice added. But if nothing happens in a situation that there's a fracture, whether it's a hairline or whether it's something like super major, we experience shock to the body. And I think that's what we want to avoid in this conversation. We want to talk about experiences that we've had in our own community, in our own, health departments, and how does that look when there's a fractured relationship between the people that you're hired and legislated to serve and from the people that are actually accessing the care and the resources that are somewhat vulnerable and depending upon you, me, us, to actually deliver that service. So I want to start with our first question, asking our panelists, and I'll ask Dr. Ellinger to lead us off with this question, and then pass the mic to Dr. Neve. The first question is, tell us about a time that you actually had to work around or deal with having the fractured relationship between the state agency and the community, and follow that maybe with actions that you needed or that you took in order to repair that relationship. Of course, there's always that opportunity to reflect. Did you, or in this situation now, would you do anything differently than before? Dr. Ellinger.
Well, thank you for that question, Alice. And I'm really pleased to be here today. And I love the theme of this because as I've learned in public health, and I think public health knows in general, that health is in relationship. Talking about the health of an isolated individual, as Wendell Berry said, is a contradiction in terms. The smallest unit of health is the community. And so those relationships are important. Health is in relationships. And I know that you're going to be talking about marginalized communities, disadvantaged communities. But I also want to highlight to the fact that as a state health official in Minnesota, there were a lot of other communities that I had to pay attention to. I had to pay attention to the medical community, the policy community, the local public health community, the media. And some of the greatest fractures in relationships were with some of those where my role as a regulator or as a quality assurance person really caused some fractures in that. So I just want to make sure that people recognize that all relationships are important and that those relationships are going to be there for a long time. So you have to find ways to repair those relationships if they're broken and find ways to make them long lasting, because if in this field, you're always going to have to come back to that community. But more specific to what I think your focus is on communities that have been disadvantaged for whatever reason. And certainly in my state, the American Indian population has historical trauma, and the genocide that has occurred has a long-standing fracture between the colonizing and white population and that community. And more recently with some of the immigrants coming in, particularly the Somali immigrants who have come in. And one thing that in that relationship that came out when there was supposedly the link between measles, mumps, and rubella vaccine and autism in the Somali community. It caused a big rift in that relationship because the community thought that we were picking on them. And that caused a fracture that really discouraged the Somali community from getting immunizations overall, not just the MMR. And so we had to try to repair that relationship. And the relationship we did is, one, you meet with them and you explain your role. You're clear about your role, but you also listen to what they are saying and try to bring them into the problem-solving nature of dealing with that issue. And trying to get elders in the community, the leaders in the community, to become partners with you in moving forward. So that was the one most recently and relevant to the topic today that I worked on.
Thank you. Dr. Neve, would you like to respond?
Well, thank you, Alice, for the invitation, and thank you to the audience for participating today. I think I'll take a little, I'm not with, State Department, I'm with an academic medical center, but I think, the analogs are fair and real. And so I'm pretty sure that folks can appreciate some of the things that I'll bring to the table from an academic medical standpoint and community standpoint. UT Southwestern happens to be in Dallas, doesn't happen to be in Dallas, it's of Dallas, Texas. And years ago, before I got here to the institution, I've been here 8 years now, and maybe I should, for context purposes, give you a little bit about my role. My role is, the easiest way to think about it is external affairs, and that includes every entity that Dr. Ellinger talked about, whether that's media, whether that's community affairs, corporate affairs. It really cuts across government affairs, it really cuts across. But this role didn't exist before I got here. And there was a hospital here, right outside my right here. For many years, it was St. Paul's was the hospital, and some of you know Dallas would know it was sort of across the street from, diagonally across the street from Parkland Hospital, which is famous, world famous county hospital. Parkland's still a phenomenal place, probably the best community hospital in the country. And we're the physicians in that county hospital. And then there's a children's hospital, and we're the physicians in that hospital. But in the St. Paul's Hospital, it was called an open clinic model, and so there were community physicians there. That hospital had actually been gifted to us, again, predates me, so well over 10 years ago, it was gifted to the institution. So well over 15 years ago, I should say, it was gifted to the institution. And the institution made the decision to close that hospital and to actually knock that hospital down. And it was the right decision, because the hospital was circa 1960. It was on hard times. It was less expensive to replace the hospital than it was to keep maintaining it. But what was underappreciated was that those community doctors that were in there were, many of the African-American physicians practiced in that facility. And when that hospital was taken down, they were displaced, because the new hospital, which is now called Clements University Hospital, is a closed model. So it's a UT Southwestern physician model. So again, with that displacement, one could say, well, of course, those individuals just went off and practiced in other places. That wouldn't be the right way to think about this, because patients had been coming to this one place to see a particular doctor. It doesn't mean they couldn't come to our new hospital, but it wasn't the same experience that they were looking for, whether it was could have been racial concordant physician, or it just could have been a physician that they have had a longstanding relationship with. And as I said, this position didn't exist. So there wasn't someone that was there doing all of the hard listening to the community to understand what would be lost. Again, this hospital would have come down and new hospital would have been built, but what would have been different if there was, sort of a community affairs, outward facing, inbound listener to the community. So fast forward, that all occurs. I actually get here when the new hospital opens, and I'm very active in the community. I'm hearing these stories that no one is told to anyone in leadership here at UT Southwestern, because we're the ivory tower, and it's a lot of mumbling in the community about what had gone on here, and I think a lot of pain for what had gone on here from the community. And this is still pre-pandemic at this point. So I took it upon myself and with a couple of colleagues to really go on a listening tour. Now it's post the event happening, but I was so surprised at how appreciative the community was and is that we took the time to listen. And I'll fast forward, because I know you've got lots of other questions, to the net result of what has happened. And I'll talk more about this throughout, the session. But after literally 300 sessions of listening, we built a 180,000 square foot clinic in the African-American and Hispanic community. It's an area called Oak Cliff, proximal to that population. It is the most beautiful clinic you'll ever see, as any clinic. It stands up against any clinic we have literally on campus. We took an old Sears as part of a mall and turn that into this clinic. And yes, you might think of that square white box, of what a Sears looks like. Just imagine cutting that in half, putting a beautiful garden in the middle, bright windows, just incredible. And the community has not, it was busy. We had 3 physicians. We had to hire 3 more within 6 months because the place is just busy. And we had no appreciation. I shouldn't say we had no appreciation. We had limited appreciation for the need in that community, which is only 8 miles away from this campus. And so it's been, I could take the story in multiple directions, but it has also just been financially successful because those people need care. Then unfortunately, that's the first time they go see a physician, and we find something that needs to bring them into the hospital here, right? So it's having massively important impact in that community. And, that could have been done pre as opposed to post if there was that kind of, whether it's a role or whether it was just that intentionality about listening to community when you're making big changes that impact community.
Wow. Thank you. Thank you. Oh, wow. So much I could say about that, but I'm going to move to our next question and can't wait to hear more about what's happening in Dallas and this particular community. I want to move to asking Dr. Ellinger, you mentioned across sectors, how you have had and the importance of navigating the multiple relationships, roles, and responsibilities that show up in what we call health, everybody's business. So can you talk a little bit about policies that state agencies are in need of in order to build more of a transformational relationship instead of the transactional relationship that unfortunately exists in some of our models today?
If we're going to really be successful as a public health agency, a governmental public health agency, I think we have to take a little bit broader view of public health. Following what the Institute of Medicine said, public health is what we do collectively to assure the conditions in which people can be healthy. Doesn't talk about what state health departments can do, or what local health departments can do, or what hospitals can do, what we do collectively. And so that means that public health is not a place of employment. Public health is a philosophy. And those of us who've worked in governmental public health, we have a certain role to play, but we are not the only public health workers in the area. We have to work collectively. So it's taking a much more team-based approach. We have to think more horizontally than vertically in terms of how we do our work. And we have to recognize that we all bring different things to the table, and all things are important. We certainly bring the regulatory piece. That's what we're provided, that's our job, and that's what the law says. And we bring a lot of data. a lot of quantitative data, but we don't bring always the qualitative data, the lived experience data that are just as powerful in terms of decision making. So we have to recognize that we have all those partners at all levels of government, but also all levels within the community. And if we start taking that way of bringing them together, we will, actually move the policies that are necessary to move us forward. The other thing that in that process, in terms of relationship, recognizing the importance of a group actually raises their power. And I'd say that it is public health malpractice if our work does not create the capacity for communities to create their own healthy future. If we're not building capacity in communities, it's public health malpractice. And so that is where the relationships really need to start. We are in this collectively. We're not the only agency in town working on public health.
Wow, public health malpractice.
Mhm.
Let that sink, right? So Dr. Neve, I'd be interested in hearing you share, are there any specific policies or infrastructure changes? I'm sure there were, that on the onset of trying to shift this whole paradigm around access to care in this community that you'd like to lift up?
Yeah, I mean, I think, as I said, it takes conversation. I think that's critically important. There's a phrase that I'm so tired of hearing, especially in the beginning of the pandemic, that Black people don't trust the whether it's the medical system or the public health system. It's usually framed as medical, and just that language, and Black folks say that too, by the way. But the more appropriate way to state that is, the medical community has lost that trust, has really disenfranchised the community in a way that it hasn't yet earned that trust back. I guess that's the better way to state it. That it's not that we don't trust the healthcare system; they've not earned the right for us to trust them. And you all know all of the things that validate that point. And so I think that's where these conversations are critical, right? This is where representation is critical, right? People who look like you in the community, representing, whether it's the public health departments, whether it's the academic institutions, the medical centers, hospitals, et cetera. All of those things matter. So, when you say infrastructure is not just a physical set of infrastructure, but are there people that are trusted at your institution, in your department, value add? How do you show up in community? Do you only show up when you're trying to get people in a clinical trial? Do you only show up when you're trying to vaccinate? Or do you have a constant presence? Is there a constancy of presence in that community by, again, whether it's the public health infrastructure? I fall into this trap also, that I want to avoid, which is talking about public health and medicine as two different things. Medicine is public health. A physician is part, whether a physician knows it or not. And I've had arguments with physicians that don't believe they're part of the public health workforce. And so physicians are part of the public health workforce. So I just want to be, as clear as possible that they're one and the same is how I think about it. One is, the difference obviously is, one is focused on prevention, but the other one is equally important when health is lost, to repair. So they're all part of the public health, ecosystem.
Awesome. Wow. So here's what I want to do now. I want to shift us because we do not have a lot of time left in this space. And I know that people came at 4:00 Eastern time in the afternoon to hear some key nuggets around how do we operationalize equity, or where do we start with advancing equity. So given your experience, you, Dr. Ellinger, known for your social justice work and moving things forward in public health in Minnesota and across several other tables, and you, Dr. Neve, with AAMC, taking as a chief diversity officer, taking your experience over the span of those years, what do you think, or how would you describe the role in community engagement and how important it is in creating what we consider health equity to achieve optimal health for all? So I feel like I said a lot of things. I'm gonna put the question in the chat here, but really, what are the key nuggets there?
Dr. Ellinger, you want to start?
Yeah, I think the most important thing, and this is certainly as a state health official, where I had a bully pulpit, we have to change the narrative about what creates health. We have to change the narrative from that it's all about personal choices and good medical care and that creates health. No, it is about the conditions and the social environment and the policy conditions that create that creates the conditions in which people live. And so we need to change that understanding, that narrative. And as you mentioned, central to that is the whole idea of social justice, because what we're finding is that inequities are an existential challenge in our community. We certainly know that in Minneapolis, where we've had, racial unrest because of the murder of George Floyd, because of the inequities that were there. It is an existential issue, and communities, the only way we're going to address that existential issue and all the other existential issues that we have, like climate change and pandemics and nuclear war, is by getting communities engaged and building power in communities so that they can create their own healthy future and building healthy relationships and partnerships.
I would add to that by saying, if you look at the mission statement of many of our institutions, whether it's public health institutions, whether they're state agencies, federal agencies, again, clinics, hospitals, most of the mission statements end with something like improve the health of the public. And that's the goal. But what's missing in that goal is, I would argue, is improve the health of the public and eradicate health disparities. And the reason why you need to be intentional in that is you can actually improve the health of the public while exacerbating disparities in one or two or three groups. And so it's not this just do everything, all boats rise. It has to be a focus, an eye on eradicating those health disparities. And there are things you do, like if you think of that as now the core, in fact, in academic medicine, we often make the mistake of saying we have a tripartite mission. We educate, we research, and we provide care. That's what we do. That's not the mission. Those are the functions of what we do. But the mission is to increase and improve the health of the public. And as I would say, I would argue for eradicating the health disparities. Now, what would you do? What are the levers, if you will, to pull to achieve that mission? There are multiple, but if, for ease of conversation, diversifying the workforce is critically important. Being inclusive in terms of bringing everybody to the table, improving their ability to partner and be with and in service of community, and certainly equity overall, because yes, there's the equitable lens that we want for patient outcomes, but there's also the equitable lens internally in our institutions that people are afforded the opportunity to bring their best selves, whether that's to the patient or bring their best selves to work or whatever the case may be. Those things are inextricably linked, and I think we talk about them often in the silos that they show up in, but we need to be thinking about Venn diagrams as we think about this work.
Wow. Okay. So I'm going to squeeze one more question. Okay. So what do you feel? Because in this room, we have representing not only state governmental public health agencies, we have local public health agencies, we have community-based organizations, we have students, we have wide representation here, right? And so what do you feel is the key to success in building lasting and sustainable relationships between all represented when we define community, right? Because community can change based on a lot of demographics, of course, and of course, even the work that's at hand. So just lasting and sustainable relationships that we can move past COVID and we can work 10 years from now on something that we haven't even imagined yet. So what are some key nuggets that you would share in your part in our last 2 minutes? Whoever wants to go first.
As I mentioned, as we started out, we all do this collectively, and everybody has a role to play. And to make the biggest time, the most effectiveness that I've had is when I've had an inside and outside game in changing policies, where communities are empowered to force us to do what we already wanted to do. We got the data, we have the access to the politicians, and they have access to us. It is an inside outside game, building community power to get them to advocate for social justice change, for political change that impacts the community, and that we listen to them and we see them as partners, not as adversaries, but as partners. You know, and they can challenge us, you know, which it's always good because tension is good as long as it's moving us forward. So it's that inside outside game that I think is most important. We all have a role to play.
Yeah. So there's a lot in my head in answering this question, but I'll try to be short here. So my mother used to tell me this when I was a kid. My mother was a community activist. My mother is a community activist. She'd say, politicians hurt those the most who can hurt them the least. So I'll say that again. Politicians hurt those the most that can hurt them the least. And so I'm in a position of power and privilege at this major academic medical center. I have the ability to lend, share, give some of that power and influence to our community organizations. I can do that in tangible ways. For example, I have a budget that's just designated to give money to fundraise for our community here in Dallas. And so have not an insignificant amount of money that is solely at my discretion. I have a committee that works with me, so it's not me alone making the decision, but it says this entity is important to us. It's important to this community. It doesn't do anything directly with the medical center, but it is an asset in the community, and we want to support that group. So there's tangible budgeted money that we're not asking for anything in return for. There are some that are critical, whether it's our students run through that particular clinic and something's going to happen to that clinic. It's then sometimes there is self-interest. It's in our best interest to continue to support that clinic. And, you know, when some dish money gets, you know, pulled, you know, we can support them for a period of time to the tune of $1 million we did this past year for one particular entity. But we have the ability to empower. The powerful have the ability to empower, right? We're a state agency. It's a state-supported medical school. The institution is so powerful, the politicians are not going to hurt this institution, right? It's not in their interest to hurt, but somebody's going to get hurt because that's the nature of our politics. And what we can do is to say, no, not that group is not getting hurt. No, this group's not going to get hurt. They're our friends. They're our partners. They're our community. And that's why I started with We Are of Dallas, because that's what we were started actually by literally community members who thought, you know, that we needed a medical school in this particular community back in 1940s, if you can believe that. And then there are other ways beyond the hard dollars. I'm just trying to make something concrete, but there are ways that we as entities that are powerful can show up and support, you know, our friends and colleagues and those in need, and those, you know, with the least among us, we can be supportive.
Thank you. I don't want to put us past time, but I want to acknowledge it. Juan says, how do you fight the iron grip of commercial and special interest benefiting from the status quo, especially in the determination of law and policies in the area of political determinants of health? Is there a quick word of wisdom that you would share to Juan? I'm sorry.
You know, our healthcare system is not based on social justice. It is a commodity. It is a business. It focuses on profit. It doesn't focus on health. And that is one of the narrative changes that we have to address. It is going to be a huge challenge.
And I would say, you know, the absence of conflict is not harmony. right? The absence of conflict is apathy. And I think, you know, we have become too apathetic in terms of our ability to even understand. You know, we talk about the social determinants of health, but we don't talk about the commercial determinants of health. It's not in the average person's lingo of what we have allowed in our apathetic state, all on our phones, TikToking or whatever people do. I know I sound old saying that, but that's one of the major challenges for society, just to be frank.
And I like
Wow.
in the chat, somebody said health is not a zero-sum game. And we have to get rid of that notion that it's a zero-sum game. We all, as Paul Wellstone, our senator, said, we all do better when we all do better. And this, even as we reduce the disparities, everybody gets better.
Absolutely. Thank you so much, Dr. Ellinger and Dr. Neve. This has been fruitful, and we are going to continue the conversation. Keep your questions coming through the chat. We will figure out the way to get responses back to you and communicate. But more importantly, I want us to be able to continue in this conversation. So now I'm going to turn it over to my colleague and friend, Philip Barnhart. Lead us, Philip.
Thank you so much for the wonderful, wonderful information, both of you, and Alice for a beautiful facilitation. For more equitable accessibility, I'd like to provide a physical description of myself. I am a white man in my late 50s. I'm clean shaven and bald, and I'm wearing glasses today. So now we're going to switch over into some breakout rooms based on topics. And Autumn, thank you very much, has put onto the screen some discussion topics and guiding questions. And so we will have the ability to self-select into breakout rooms. And the breakout rooms, as titled, are a breakout room about acknowledging the inequity and fractured relationship, a breakout room on building trust and repairing the relationship, a breakout room in fostering, sustaining the relationship engagement, a breakout room on communication, and a breakout room on cultural humility / power shifting. What I would like you all to know is that you are welcome to go between breakout rooms. In fact, if you go into a breakout room and it feels a little too populated, you're welcome to dip out into another one. Somebody from the stretch team will be in each of the breakout rooms to help facilitate and help move things along. And somebody from the stretch team will remain here during the breakout session in case there are any questions or technical difficulties. You will not be coming back into the main section. So I want to thank you deeply from the bottom of my heart and on the behalf of the stretch team for attending today's get together, right? So after the breakout room closes at 5 o'clock, you will be exiting. And I believe that upon exiting, you're going to have an evaluation that pops up, right? And so please fill out that evaluation. And Jessica would like us to know that there's an accessible version that is compatible with a screen reader, and it is available by emailing her at jfeppelstein@astho.org. And maybe Jessica can put that email in the chat, or somebody can for her, because she's probably doing other things. So yes, Jessica says we have 10 rooms for each topic. Feel free to move to another room as you like. Team, is there anything that I've forgotten before we ask people to self-select? Again, thank you so much to our expert speakers and to everyone who is joining us today. Okay, and you should have a little thing that says join a breakout room at the bottom of your screen. And I'll stay in here for a minute to see who else is going to stay in here, and I'll join a breakout room too eventually.